I'll start with the talk about benign tumors and tumor-like lesions. A very famous person, Steve McGee, who was an expert on radiation-linked diseases in the human body, said that I found it strange that I had a large benign tumor on the tendon sheets of the knee joint. As the tumor grows in the joint, it damages the surrounding bone and tissues if not removed promptly. I later researched the toxicity of a very high altitude facility and realized that I was working in a very abnormal biological environment that was clearly doing strange things to workers' health. So this depicts the importance of the environment that we are having and the frequency of tumors that we are facing now. So the goals of this presentation are basically evaluation of bone tumors, their aggressiveness, non-aggressiveness, review some of the common bone tumors, uncommon lesions, and once we have done diagnosis by histology, staging, and biopsy, how to manage them. So whenever we come across in our clinics or in the setup a patient with pain, mass, or pathological fracture, we suspect a bone lesion. So when we see a bone lesion on an X-ray or clinically, then we see where is the site, its distribution, the morphology of the tumor, and after these, the various imaging techniques that we have. So starting from the clinical features to suspicion of the bone lesion to its morphology and imaging, we end up in differential diagnosis. Once we have made the differential diagnosis and taking in account the patient demographics like age, sex, and ethnicity, we can proceed towards biopsy, which is the gold standard for any tumor. This all is based to diagnose what the lesion is. So until unless we diagnose the bone lesion, we don't progress any further. So talking about benign tumors, as we all come across, you should remember they are non-life threatening, they do not metastasize, and simple observation to surgical excision can be the treatment. Important factors in diagnosing a bone tumor include, as I told you before, the patient age and gender, the bone involved, the location of the tumor along with our bone, the margins of the lesion, the matrix proliferation, and periosteal reaction. So these are all very important radiological and clinical features which will help us to aid in diagnosing the tumors. So a brief account of, as we all know, I'll give you a brief account of the WHO classification, which says that bones can be divided into osteoid forming tumors, like bone forming tumors, which start from anastosis, osteoma, osteoma, and osteoblastoma. They are all dependent on the size, the smallest being the anastosis, the largest being the osteoblastoma. And their distribution, usually anastosis is in the axial skeleton along the epiphysis, and they are usually in the medullary cavity. So osteopoikilosis, one of the conditions we come across is basically anastosis or multiple bony islands. The other form, the osteoma, usually they appear in sinuses or the skull bones, and they are usually cortical. The osteoid osteoma being common in bone-forming tumors, they usually in the long bones, in the diaphysis, and can appear in the cortices. Osteoblastoma, a bigger lesion, usually we find them in the spine, in the femur, tibia, and they are usually in the diaphyso-metaphyseal junction, and they are usually central as compared to osteoid osteoma, which are eccentric. Then cartilage-forming tumors, as we all know, osteochondroma and chondroma, juxtacortical chondroma, chondroblastoma, and chondromyxoid fibroma. And osteochondroma being the most common bone tumor, which is osteochondroma. Again, it is in the long bones, usually on the surface, and chondroma is in small bones, and usually they are central. and juxtacortical chondroma, which are again a long bones in the metaphysis. Chondroblastoma, one of the rare tumors, usually in growing children, is usually in the epiphysis and is eccentric. Then comes the chondromyxoid fibroma, which is usually seen in the tibia or long bones and is in eccentric location. Then fibrous lesions, I'll just name them, the commonest being the fibrous dysplasia, fibrous xanthoma, osteofibrous dysplasia, and desmoplastic fibroma. I'll be giving you details of these uncommon tumors in my subsequent talks. Then other lesions which may mimic like tumors can be intraosseous lipoma, osseous, which is usually seen in the calcaneum, the osseous hemangioma seen in the vertebrae, the giant cell tumor, one of the most aggressive benign tumors, usually seen in the long bone epiphysis and metaphyseal junctions, and usually they are eccentric. Then we have simple bone cysts and aneurysmal bone cysts. Then the modalities that we use for imaging the tumors is the radiograph, plain radiograph. It has got a very good diagnostic strength. Proper views can really make your diagnosis easy. The other thing we use is a CT scan, which has a greater resolution than X-ray, and we can also do a CT guided biopsy. MRI is the revolutionary investigation, where we can see the soft tissue contrast. There is no radiation involved. We can even see the marrow-based lesions, the internal tumor composition, and we can also stage the tumor by seeing that it's neurovascular involvement or skip lesions. The other non-invasive investigation we use is an ultrasound, although it has got a limited use. We can differentiate between a solid and a cystic tumor. It can tell about the vascularity of the tumor, and we can also do the ultrasound guided biopsy. Coming to the latest investigations, the PET scan. This can tell you about the tumor viability and its metabolic activity, and it does help in differentiating between benign and malignant lesions. The whole body scan, the technetium 99 bone scan, assesses the entire skeleton. The disadvantages of all except the MRI are that they all have radiation. MRI being expensive, and people can be claustrophobic to it. So again, in the evaluation, as I told you, the history is the cornerstone. So we should know about the age and sex and the race. So age being very important. Just an example, in the first decade, we can see the aneurysmal bone cyst or the simple bone cyst. In the second decade, we can see the chondroblastoma and the other malignant forms like osteogenic sarcoma and Ewing sarcoma. In the third decade, we can see the giant cell tumor. In the fourth, fifth, we see the slow-growing tumors like the chondrosarcoma and multiple myeloma. Sex is a lesser important heading, but giant cell tumor is more common in females. And as in Ewing sarcoma is found rare in the African race. Then we should also inquire about any exposure to the radiation, to teratogens, to carcinogens, and to radionuclide exposure. Various chemicals like methylcholanthrin, zinc, beryllium silicate, and beryllium oxide can also be the precursors of tumors. Currently, the most worrisome and controversial is nickel, which is used in many of the orthopedic implants. So once when we have seen the history, we have taken the examination, we have done the examination, and we have seen the X-rays, then we see the behavior of the lesion to the bone and what does the bone do to the lesion. So we have to then inquire about the pattern of destruction, the bony resorption of the lesion, and the matrix calcification. So whenever we find a geographic the pattern, that means that the bone has a good time to repair, and it limits the growth of the tumor. So these are usually seen in benign tumors. Then we see the permeative and the moth-eaten. So the bone has a lesser time to react, and the bone is eaten up before there's time to repair, and these lesions are seen in aggressive tumors like osteogenic or Ewing sarcoma. Then the next thing we should look for is the lesion margins and the periosteal new ball formation. If there is a narrow zone of transition, that means that the bone has time to repair, and the lesion is long-standing and is non-aggressive. But when we see there is a wide zone of the transition, that means that the bone had no time to respond because of the fast-growing tumor and its aggressiveness. So we see that there are no borders of the lesion and it's all over the bone. So just to remember the narrow zone of transition and the wide zone of transition. Then the periosteal reaction in benign lesions, as we all know, there is ample time for the bone to react, and the periosteum can be thickened, dense, and even appear sclerotic. But in malignant tumors, you will see that the periosteum will be hyperreactive. So there will be various sort of patterns, which I'm going to show you subsequently. But at times, infections and aneurysmal bone cysts can have a similar periosteal reaction. So if you see a solid reaction of periosteum as seen in the center, that means that it is a benign lesion like an osteoid osteoma, which the bone has tried to contain. But then there are multi-layered onion skinning, spiculated hair ends, or Codman's triangle, or intraoperative onion skin. That means of the rapid growth of the tumor, and the bone is unable to control it. So it throws a lot of periosteum cells, and which line up in bundles or layers or in spicules. So once we have diagnosed this, the cornerstone of management is tumor biopsy. As we are all aware that tumor biopsy it will determine the fate of the patient. So it is done to determine the characteristics and local extent of the tumor. It helps us to stage the tumor and where does the patient stand and where do we start the treatment. And biopsy should be done before radiology, because otherwise this will superimpose the radiological findings and the radiology will be useless. The second principle will be to make a small incision whenever possible in the skin and capsule, and the biopsy tract should be considered to be contaminated with tumor cells. So whenever we do a biopsy incision, it should subsequently be taken out along with the definite surgery. The surgeon doing the biopsy should be the surgeon who is also performing the definitive surgery. So he should be familiar with limb salvage surgery and with standard and non-standard amputation flaps. And caution should be utilized to limit soft tissue contamination. If a tourniquet is used, the limb should be elevated and it should not be smart or assimilated, so that the tumor cells are not propelled up. As again I told you, we shouldn't contaminate the tissues, and we should avoid transverse incisions, and the deep incisions should go through the muscle rather than through the intermuscular planes. We should avoid the neurovascular structures, and care must be taken not to contaminate the flaps with a minimal retraction and soft tissue injury. If possible, the soft tissue extension of bone should be sampled. And if we make a hole in the bone, it should be a round or a longitudinal oval hole, so that it doesn't end up in a stress fracture. At times, a fracture may preclude limb salvage surgery, so we might need a bone plug to control the hematoma. Biopsy should be taken from the periphery of the lesion, which contains the most viable tissue, and the biopsy material should be sent from multiple culture sensitivities if in doubt regarding infection. So, as one of the sayings of our professors is that we should always do a biopsy for an infection and a culture for a tumor. A frozen section, when available, should be sent intra-op to ensure that the diagnostic tissue has been obtained. If a tourniquet has been used, it should be deflated, and meticulous hemostasis should be done before the closure. Drains should not be used routinely, and if they are used, it should be used in the line of incision. And the bone should be closed like watertight. And if the operating team or the surgeon should accompany the specimens to the pathologist and discuss his diagnostic and clinical findings along with the specimen so that they make a definite diagnosis. So this is a brief photographic sketch about the biopsy. See, a longitudinal incision is being made. We make a small longitudinal incision, which should be closed very tightly. Multiple cultures are taken. We take a wedge from the bone, and we should approach directly with the shortest route to the tumor rather than going in the multiple sites. This, as I discussed before, the WHO classification: bone forming, cartilage forming, and marrow forming tumors. So in benign tumors, Nadeem described that there are three types or three stages: a latent stage, an active stage, and an aggressive stage. Or a tumor can be latent with a well-demarcated borders. They grow slowly and heal spontaneously like an osteoid. They can be active with well-defined borders, but may show cortical thinning like an aneurysmal bone cyst. And growth may be limited by natural barriers. Then they can be aggressive tumors, as I told you before, the giant cell tumor being the most aggressive, and growth is not limited by natural barriers. And 5% of these tumors can metastasize. So this gives us a clue about the nature of the tumor. I'll skip the malignant ones. We'll discuss them on the malignant side. Just another slide, the stage 1 tumors, they're usually treated by intracapsular excision like curettage. The entire stage 2 tumors, they are usually treated by extracapsular, passing through the reactive zone. And for aggressive tumors, we use resection in areas that are not amenable to wide excision. Marginal excision with adjuvant therapy like radiotherapy can be used. This picture, as we are all very familiar, gives us just a small clue as what we are dealing with. So starting from the bottom, if some lesion appears in the epiphysis and it is the child, then the most likely chances it's a chondroblastoma. If it's just a juxta-epiphyseal, then we are encountering with the giant cell tumor. Going more further to the metaphysis, we can see benign tumors like osteochondroma and simple bone cysts which can extend up till the diaphysis. Coming to the cortical part of the bone, we see, the commonest thing we see is a chondromyxoid fibroma or an aneurysmal bone cyst. Then in the diaphysis, we come across the fibrous dysplasia. And again in the diaphysis, at the site of the periosteum or at the cortex, we find the most common tumor, the osteoma. There are also other things like stress fracture and osteomyelitis, but for tumor, this is common. Then again in the cortex, if we find a defect, the commonest diagnosis is a non-ossifying fibroma. So this just gives us a clue of what we are searching for. Now coming to specific tumors, I'll start with the osteoid. It was first described by Jaff in 1935. It's basically 12% of all the bone tumors, and it is a really painful tumor. And if the pain is severe in night because of the release of prostaglandins, and it's usually relieved by aspirin or any analgesics. Depending on the location, patient may present with bony deformity, gait disturbance, and if it's in the spine, even as scoliosis. So this is a very subtle image of the osteoid. If you look closer, there's a small nidus in the center surrounded by a rim of bone sclerosis. Incidence is usually in 5 to 25 years of age. Males have more predilection, and 50% of lesions are in the lower limb. This is a small lesion on the X-ray, the rounded one. This is osteoidostoma seen in the pelvis. Again, a young girl showing typical symptoms of features of osteoidostoma. This is the nidus. This is the sclerotic rim. And I told you the distribution of the tumor is usually eccentric, and the periosteal reaction usually is very solid. When grossly seen, the specimen of osteoidostoma, you can see a central area nidus with osteoblastic rimming and area of thickened bone and fibrovascular tissue. So this is whole lesion with the nidus. On histology, we see a small circumscribed lesion with trabeculae. You see these are all the osteoid. This is all the osteoid, the central nidus, with variable mineralization and rimmed by a single layer of osteoblast plus frequent osteoclast. We can also see loose fibrovascular stroma surrounded by thick sclerotic bone. So the key is to see the osteoid. Again, CT scan showing in the proximal part of the tibia. There can be, again, three subtypes. The most common is the cortical, as I told you before, but you can see these lesions in the medulla and as well as the metaphysis. CT is usually the diagnostic modality of choice. And dynamic contrast CT has been reported to be useful in differentiating osteoid osteoma from bone cyst and chronic osteomyelitis like Brody's abscess. Bone scan is a highly sensitive diagnostic modality for detecting and localizing osteoid osteoma. This is an algorithm. If we come across an osteoid osteoma and if we plan for non-surgical treatment, then we usually keep them on rest and analgesics. But if there is worsening pain or if there are any complications like scoliosis or the patient's preference is surgery, and if there is any contraindication to NSAIDs, then we go for surgical management, which is again divided into two parts. If it's located in the vertebral column or in close to peripheral nerves, fingers, toes, or carpals, we go for an open surgical excision. But in locations, excluding the others that I told you, we need to have minimal invasive procedures, CT guided ablation, other techniques, and for recurrent lesions, again, we can go for CT guided radiofrequency ablation. We can also use burrs to remove the lesions. This is a typical boy with lesions, coming with night pains. This is how we can remove the burr. The central nidus is then curated and scooped out, and we can clear the whole lesion. The next outline is the osteochondroma, and this is supposed to be the most common benign tumors and accounts for 10 to 15% of all bone tumors and approximately 35% of all benign tumors. There is no sex direction, so males and females can be equally affected. Basically, it's an outgrowth of the bony plate and made up of bony cartilage. It's also known as exostosis. This is a typical appearance of a patient coming to your clinic with a hard mass, not immobile, hard, painless mass around the knee or around the shoulder. So a simple X-ray can lead to the diagnosis, and also at the back of the knee. This is how it can appear, like multiple exostosis. This is the benign variety. We see the cartilage cap, the bony rim, but again, this tumor can, you see the benign part converting into malignant part, chondrosarcoma, so this can end up in a chondrosarcoma. Clinically, these patients usually complain of pain, tingling sensations, and when you examine, there is a non-tender immovable mass arising near the end of the long bones. A symptomatic lesion can cause irritation of the overlying soft tissue, secondary to bursitis. X-ray, you can see the two types of lesions, either can be sessile or pedunculated. And the importance is of the cartilage cap. So the MRI is basically to assess the cartilage thickness, and thus assessing the malignant transformation, the presence of edema in the bone and adjacent soft tissue, and visualization of the neurovascular structures in the vicinity. So to see its progress, MRI is very helpful. This is an example of an osteochondroma which was removed and subsequently showing healing. The gross appearance, as I told you, is a cartilage cap, big cartilage cap, and this is the bone. So that's the combination of areas of calcification, bone along with cartilage cap. On histology, these star areas showing is the yellow marrow. The trabeculae are the straight arrows. You can see these are the trabeculae, and this grayish bluish area is the cartilage cap. So you can see the hole, and the upper part is the fibrous capsule or the perichondrium. So histologically, this is a typical appearance of osteochondroma. If it's a small asymptomatic tumor, we don't need to do anything, just observe and reassure the patient. If it's causing irritation and pain or bursitis, then we can go for wide local excision. The features that make it cancer, that it can be cancerous transformation, can be remembered by a mnemonic glad past. So if there is any growth after skeletal maturity, if you see new lesions, if there is additional scintigraphy activity like changes in the MRI, if there is destruction of the cortex, if there is pain after puberty, if there is a big soft tissue mass, or if the cartilage cap is bigger than 1.5 centimeters. So these should startle you, and you should look for malignancy. The next common tumor we can encounter is an enchondroma, usually involving the bones of the hand and the feet. And basically, this is associated with Olier's disease and Maffucci syndrome. These are associated with vascular tumors and ovarian tumors. So it's the second most common benign tumor lesion, benign lesion of the cartilage. Again, there is no male-female difference. Usually 20 start from the second to the fifth decade. Usually they are medullary. And the most common, as I told you before, is 60% of them involve the hands and the feet. Other locations can be the distal femur and the proximal humerus. Even they can appear like these bubbly bones, as seen in Olier's disease. The majority of enchondromas remain asymptomatic and usually require no treatment. They can be followed 6 monthly or yearly, or if there is any new change. If there are pathological fractures, they can usually be treated by curettage and bone grafting, and follow-up X-rays are seen until the bone has healed, and the incisional biopsy obtained intraoperatively is clear. Recurrence is reported in around 2 to 15% and does suggest malignancy. If malignant transformation is suspected, which is again 5% of the cases, then treatment is more aggressive. Again, you see a small enchondroma, the base of the pelvis. Pathological fracture along with the enchondroma. High uptake on the bone scan. So next tumor, which is uncommon but very notorious tumor, is the chondroblastoma. So this usually appears in children, usually around the growth plate, and before skeletal maturity. You see just juxtaepiphyseal, and on scan you see a large big lesion. So it is rarer and appears around the epiphysis or apophysis. And one of the features is it does have a more male predilection and one of the locally metastasizing tumors. So it is only benign tumor which can have the potential to metastasize. This is the gross appearance. The lesion will show a well-defined geographic bone distribution. As I told you, the bone has limited its growth. Either oval, spherical, triangular, and there may be amorphous calcific foci in the lesion. This is the typical appearance on histology. They appear like chicken wire. Chicken wire as in you see netting for holding chicken. So they appear like net or cobblestones. But this is typical of chondroblastoma. So it has got multinuclear giant cells, chondroid matrix. Again, a lesion in the distal femur. You see a well-defined radiolucent area with smooth or lobulated margins and thin sclerotic rim. Similar lesion in the tibia involving the whole of the epiphysis in a skeletally immature patient, involving the proximal fibula. On a CT, you can see how it appears, how big this lesion is and how close it is to the epiphysis. So this is the CT and the MRI. So the MRI is ideal for evaluation of transphysial or transcortical extension and for demonstrating associated surrounding bone marrow and soft tissue edema, which is seen in a large portion of cases. And the CT scan demonstrates the plain film findings with better delineation of the relationship to the growth plate and articular surface. So these tumors are notorious to damage the growth plates. So whenever they are taken out, they end up in some residue and they do have some damage to the growth plate. Treatment usually consists of curettage and packing and with bone cement or bone graft. And this radiofrequency ablation can also be used for inaccessible areas. As I told you, unfortunately, due to its proximity to the epiphysis, there is complete eradication is difficult. As a result, recurrence rate is very high, around 20%. And injury to the growth plate may result in growth arrest. Then we come to simpler things like simple bone cyst. These are usually metaphysio-diaphyseal lesions, and with growth they can end up in the diaphysis. So they are serious fluid-filled bone lesions thought to result from temporary failure of medullary bone formation. They are usually seen in patients in this second decade, typically found in the proximal humerus or femur. Can be found in other locations like, again, I told you, femur, tibia, ilium, calcaneum, and arises always from the metaphysis and can grow up to the diaphysis. This is typical histological appearance, a cyst with fibrous lining containing fibrous tissue and multinucleated giant cells. Again, this is seen in the roof of the acetabulum, the distal tibia. There is also a sign known as a fallen leaf or a fallen fragment sign, which is seen typically in bone cysts. So this fragment, or there might be a bubble appearance because there is a fluid filled and air can be trapped and you can see a bubble here. So these are typical findings of simple bone cysts. These are the various treatment that we have given. It's a simple bone cyst which is filled with bone cement, and again a bone cyst which is treated by injection of multiple corticosteroids and ending up with healing. So Scaglietti in 97 proposed multiple steroid injections and have been effectively used because of its simplicity and high healing rate. People have also used bone marrow alone or in combination with demonized bone matrix as an alternate to steroids for treating unicameral bone cysts. Then we come to aneurysmal bone cysts. This was again first described in 1942 by Jeff, who coined the term aneurysmal bone cysts because of the pathological appearance of the lesion within the bone. This is how typically it appears. This is rarer than the unicameral bone cyst, almost 0.1 per 100,000. They may be slight female preponderance. Mostly they are seen in the second decade and usually appear before the age of 20 years. Aneurysmal bone cysts can usually involve any part of the skeleton, but majority are seen in the long bones like the humerus, femur. It is also seen in the spine and the pelvis. In spine, the aneurysmal bone cysts usually involve the posterior arch, mainly of the lumbar, followed by cervical and then thoracic areas. Pelvic lesions more often involve the obturator foramen and are peripheral to the triradiate cartilage. 30% of ABCs, aneurysmal bone cysts, are secondary in reaction to another lesions such as giant cell tumor, chondroblastoma, osteoblastoma, chondromyxoid fibroma, and non-ossifying fibroma. This is typical appearance of aneurysmal bone cysts with multiple giant cells and uniform fibroblasts. Again, typical appearance of the distal in the distal radius of the aneurysmal bone cyst, involving the posterior elements of the spine. All we have extra pictures of aneurysmal bone cyst. This one is treated one. So it shows an eccentric, osteolytic, expansive, and sometimes trabeculated lesion containing fine walled cystic cavities. Internal contours are well defined with or without osseous sclerotic ring and cortical bone bulges. Loss of cortical contours, as I told you before, if there is the aggressive tumor, then there will be pathological fracture, or it can come out of the bone. They can break the bone and come out. Central locations are more often found in short hands of the bone. This is appearance in the spine. This was a solid ABC, which was spontaneously resolved after biopsy. So even if they are taking, if a biopsy is taken or they are fractured, they can heal. Again, this is the aneurysmal bone cyst involving the floor of the acetabular roof and floor, and CT has in the CT scan with the CT aspect after FE block injection, which is usually not available now. Sclerotherapy was done, and there was healing of the tumor. This is again how it can present: eccentric, multiloculated lesion. Giant cell tumor, as we all know, it's also known as osteoclastoma. Its incidence is around 18 to 23% of all benign neoplasms and around 4 to 9% of all primary bone neoplasms. Usually they are almost invariably occur after the growth plate has closed, and therefore typically seen early adulthood. There is a little more female incidence as compared to male. 80% of the cases are reported between the ages of 20 to 50, and there is a peak incidence between 20 to 30 years. This is how a giant cell tumor appears on gross examination. It's just around the epiphysis, all eaten up, and areas of hemorrhage, along with some degree of fibrosis in the bone. These are the histology findings. You can see all filled up with multiple osteoclastic giant cells, mononuclear cells, which are round, oval, and polygonal. Frequent mitotic figures in the mononuclear cells, especially in pregnant women or who are taking oral contraceptives. It is important to realize that the features may be difficult to interpret histologically with a relatively wide histological differential diagnosis. So again, history, imaging, and then biopsy is a triangle for diagnosis. So again, a typical X-ray showing eccentric lytic lesion, which is seen in the epiphyseal mesophyseal junction. Neocortex is a characteristic of benign aggressive lesion and not unique to giant cell tumor. So you should always see, get the X-ray chest to evaluate the lung mats. Treatment is usually with curettage and packing with bone chips or bone cement. Local recurrence is from the peripheral lesion and has historically recurrence rate. Monoclonal antibodies like denosumab are in vogue now, and as an adjuvant to treatment targeted tumor necrosis has shown impressive results. So the tumor is invasive and aggressive, and it commonly recurs, may become malignant after unsuccessful removal. The resection is treated with en bloc excision. En bloc excision is also indicated if the tumor has eroded the cortex and extended into the soft tissue. In the prior biopsy and other investigations, operative plan must include three factors: type of resection, use of adjuvant therapy, and type of material to be used to fill the defect. As I told you, it should be simple curettage, alone extended curettage with adjuvants, and en bloc excision, irradiation therapy, embolization, bisphosphonates, and at times amputation. Intralesional curettage exposure with large cortical window. It can be done with higher speed bursts, pulsatile lavage, and curettage alone has high recurrence rate. The advantages of using adjuvants that it eliminates the microscopic disease, and bone cement causes a 2 mm osteolytic lesion zone surrounding the cement due to thermal injury. Phenol and hydrogen peroxide has also been used. Bone cement with adriamycin methotrexate to reduce the recurrences. Bone cement again, he's told can be used, and it has got good results. When tumor is less than 1 centimeter from the articular surface, the incidence of degenerative changes in cartilage after the use of cement alone is 2.5 centimeters when the tumor is greater than 1 centimeter away. In such conditions, multiple reconstruction techniques are used. So we can use bone cement and graft, and this technique is known as the sandwich technique. Grafts or prosthesis. This technique has low recurrence rate. Again, for resection in stage 3 lesions, resection is ideal rather than removal part of the lesion. And these are done for recurrences, large defects. When the large defects are expected, joint surface destroyed or cannot be salvaged, and certain bones which can be sacrificed like lower end of ulna or upper end of fibula. Mass catheter embolization of the blood supply of unresectable tumors like sacrum and pelvis do also have role in tumor control. Finally, amputation if there is malignant transformation, fungation of the tumor, recurrence after surgery, deep-seated associated infections, extensive destruction of bone, and severe disability. So amputation can be zoledronate are also used. They target osteoclast, giant cells, and they limit tumor progression. The new drug, denosumab, as I told you, has been used for and arthrodesis and giant cell tumor which are resected, and the joint has been salvaged by using bone cement and plates. Thank you.